This is part 2 of the TRACK-TBI Clinical Core Protocol training. As we described in part 1, the most important part of the TRACK-TBI for the clinical coordinators is to identify patients that are most likely to follow up. Part of this is really explaining this study in a way to patients that they understand. Over the last 5 years, we have been barraged by the impact of TBI, whether it's in football players or soldiers returning from the conflicts in Iraq and Afghanistan. We need to explain to patients that the reason why we need for them to follow up at the 2 weeks, 3 months, 6 and 12-month time points is that we really need to understand exactly what does TBI mean. There's been lots of concerns for things like CTE, dementia, Alzheimer's, and we just really don't know. We have a lot of folks that we refer to as the walking wounded, but because we've never really followed these people up in a comprehensive way, the way that we have stroke, cancer, and heart disease patients, we really don't know. So I think it's important for the patients to understand why we're so passionate about trying to better understand what the long-term future is after somebody's sustained a traumatic brain injury, and why it's crucial that they help us by participating with follow-up. If patients don't understand this, they're probably not likely to follow up, and we really need to identify folks who are going to help us to provide the most information possible so that we can better diagnose, better classify, and better treat traumatic brain injury in the future. The participation is for all components unless contraindicated for an MRI. While the priority is MRI for the first initial cohort of patients, we can so-called fall down to the CA if additional patients are needed for a quarterly target. So for example, if we're setting out to enroll 30 patients in a quarter and we can only get 20 patients in for an MRI, then those other 10 patients can be backfilled by patients that are just the comprehensive assessment that'll get the more frequent blood draws and the comprehensive outcome assessments at the 2 weeks, 3 months, 6 months, and 12 months. We need to explain the blood draws, the amount and frequency in the ED, and the hospital up to 2 days, and at the 2 weeks and 6 months. We need to let them know that the reason why we're doing this is so that we can one day have a blood test, just like we have a blood test for the detection of heart disease and heart attacks. We need to explain the nature and the time commitment for these inpatient outcome assessments and interviews that happen at 2 weeks, 6 and 12 months, and also the telephone outcome battery at 3 months. We need to explain to them that we really don't have a very comprehensive way to look at outcome from traumatic brain injury. And one of the things that we're trying to do is we're applying multiple measures that not only look at their ability to think, but also how they're feeling, and trying to better understand what their quality of life really is. And that even though this is an exhaustive battery, that there are other studies that do testing far more comprehensive than what we're doing. And what we're really trying to do is we're trying to learn more about them. We need to talk about this time, about the MRI, that this MRI scan is targeted to take about an hour, and why we're doing this, because we believe that CT scans really may not be all the information that we need. Just like in many other areas of the neuroscience, a CT scan is not what we use today for tumors. It's not what we use for Alzheimer's disease. And we believe that MRI is going to play an important role in the diagnosis and hopefully the treatment of TBI one day. And so we really need to make the patients understand why we want them to come back for this 2-week and 6-month MRI. We also need to explain the compensation that we're providing, that we understand that this, in addition to potentially being valuable to future patients with traumatic brain injury, that we understand that there's cost to the patient and that we are trying to provide a stipend for their costs incurred and also for transportation. And as you know, we've acquired additional funds to help to encourage patients to participate in the follow-up and to help to cover their transportation expenses. We also need to explain how the data will be used and how their confidentiality will be protected, that we have the utmost of security standards to protect their private information. We also need to explain that the consent will be reviewed at each visit, and they have the right to withdraw at any time, so that if further in the study, if they decide they don't want to continue to participate, they can withdraw. However, we really want to find those patients and those subjects that want to participate for the full duration of the study. This is how we'll learn the most about traumatic brain injury. We need to review the remaining consent form elements and provide patients or surrogates with the time needed to make a decision, keeping in mind that enrollment for that first blood draw must occur in 24 hours. In terms of the screening logs, hard copy screening logs will be maintained for enrollment, and the excluded subjects will be entered into the question database. The data collected on the excluded subjects will not have any PHI and are only entered into the question as a log, not a database record. The log entries only need to include the subjects screened during the 24-hour window of enrollment. If no patients are screened on weekends or other days, then no need to document eligibility. However, we understand that TBI is often a night and weekend disease, and we will need to be screening, if possible, to capture some of these patients so that we get a more representative population. If we can get the screening log form finalized, it would be good to review some of the entries here. Procedures by core. So we'll go over the clinical core, the neuroimaging core, the biospecimens, and the outcomes. And as we've said on prior calls, we are doing 4 months worth of work that should have taken us 8 months of preparation time. So we are essentially, in some respects, laying the tracks as we're driving the train. So we will have a follow-up with the screening log, and the clinical core, neuroimaging core, biospecimens, and outcomes, operating procedures, and manuals of procedures should be done by the first week of March. The study coordinator responsibilities for the clinical core really, again, a central role in assuring that the patient retention to complete the outcome and imaging assessments and milestones. We've said this before, we'll say it again. The success of this study really depends on the study coordinators. You have to find the right subjects, you have to establish the rapport, and you have to ensure that we get the follow-up that's needed in order to make this a valuable study. One needs to maintain the current entries in the question patient management menu for the tracking contacts, for the scheduling the follow-up visits, and for transport and reimbursement. The more information that's put into the question database, the easier it will be to track these patients, and the more tools we will have to help to administer this study. This figure shows the 2-week follow-up assessments for the CA plus MRI cohort. So at 2 weeks, those folks will get an MRI scan 14 days after the injury, with a leeway of 4 days either way. Once that MRI is scheduled, we need to get those outcomes within 3 days of that 2-week MRI so that we can make sure that we understand how the outcome associates with the MRI scan. For those that can't get an MRI in the early part of the study that fall down to the CA cohort, they get outcomes at 14 days plus or minus 4 days of that 14-day time point. For the 3-month assessment, this will be done by telephone, and this will be done at 90 days after the injury, plus or minus 7 days. At 6 months follow-up, we'll get an MRI scan within 14 days. Once that MRI scan is scheduled, then the outcomes need to be done within 14 days of that 6-month MRI. Again, if one falls into the CA cohort, that'll be done at 6 months plus or minus 2 weeks. For the 12-month, again, that will be done at 12 months plus or minus 2 weeks. To assure subject compliance retention, our target follow-up rate for the 12-month duration of this study is 80%. We realize this is ambitious, but this has been done in several other TBI studies with coordinators that were focused on trying to establish rapport with the patient and really helping to get that outcome. This can be done. It's not going to be easy, but it can be done, and it has been done. The coordinators will maintain scheduled contact and establish this rapport with these subjects and their family members to ensure ongoing compliance through the 12-month study duration. The participants are going to be asked to provide multiple forms of contact, as we described in Part 1, including phones, addresses, emails, and also find out what type of communication the subject would desire. Would they want a text? Do they want a phone call? Let's try to help them out with the type of communication that they prefer. Upon their permission, participants will be asked to provide one or more alternate contacts. Again, this is very, very important. To get one number is not enough. We need to get numbers of relatives, friends, significant others, places where folks are staying. One cannot have enough contact information for patients with TBI. The research coordinators also to monitor their own site progress, which will be supplemented by an automatic reminder of upcoming windows for follow-up generated by question, and these will be emailed to the sites weekly so that you'll be able to have a running log of what the work plan will be for the week. In terms of assuring subject compliance and retention, every effort will be made to schedule the return visits at the subject's convenience, and multiple procedures for the time points will be scheduled on the same day if feasible for the location and patient tolerance. We understand that not every site's going to be the same, and some people have MRI facilities that are located in different facilities where the outcomes will be done, and we're leaving it up to the sites to ensure that as long as you follow the guidelines in terms of the timing windows, this is going to be a site-by-site dependent process. When the subjects do return for their follow-ups, they will be met by a research personnel who will escort them to the various testing locations. Subjects will have the full opportunity to ask any questions before, during, and at the end of the follow-up appointment. The site coordinators are encouraged to have relevant resource packets and materials for TBI assembled to provide to the study patients. When we have loss or incomplete CA plus MR follow-ups, if the subject can't return to the 2 weeks or 6 month time point, we need to attempt to schedule this in person. If the subjects can't return at all for the CA visits, we should at least try to get phone follow-up if possible. Again, data collection and management. More in-depth training on the ECRFs will be provided in question training with forms populated according to the emergency department, admission, and ICU enrollment groups. Hard copy CRFs need to be entered into the question in a timely manner, as weekly form status will be generated for each subject and site. Decision to generate the GUIDs or the unique identifiers via question is going to be site dependent, and you should talk to the administrative staff to understand how is the best way to do this. We think that most of these can be standardized, but some sites will have some unique issues that need to be dealt with. The data quality audits will also be conducted for each site by an external team from Baylor. For the biospecimens core, the study coordinator will be responsible for obtaining coordinating blood specimens and collections. We will have a separate training video for this, and the SOP will be updated by the 1st of March. The enrollment will require obtaining serum, plasma, RNA, and DNA. Hospital stays at 2, 5, and 7, at 2 and 5 days will receive another biospecimen retrieval for serum and plasma. At 2 weeks and 6 months, we will get serum, plasma, and RNA. This is a description, briefly, of the biospecimens core. Again, there will be more detail provided for this with a specific biospecimens training, but as you can see here, we will use an EDTA-treated blood tube, which is 1 7 ml purple top. This will be centrifuged at 1,500 grams for 15 minutes within 30 minutes of collection and processed as follows. For the serum tube, we'll use a red top tube, and this needs to be placed at room temperature at the time of collection, and within 30 minutes, this tube will then be, after it's coagulated, will be centrifuged at 1500 Gs for 15 minutes and will be processed as follows. The PAX gene tube, which will allow us to collect RNA, which has never been done broad scale for TBI, this will be done in this tube. The tube needs to sit upright at room temperature for 2 hours after collection, and then it is frozen prior to being shipped to the TRACK-TBI biospecimens repository. In terms of the shipping, the biospecimens services are planning to be relocated from UCSF, but at this point in time, they will be shipped to UCSF pending formal transfer to a long-term facility. New shipping directions and packing supplies will be delayed for a few months. For the neuroimaging core, anonymized electronic copies of the brain CTs performed in the ED will be submitted on a DVD to UCSF, and the radiologist report will also be copied into the electronic case report form. For patients admitted to the hospital, anonymized e-copies of all subsequent brain CTs and or MRIs will be submitted, and the radiologist report will also be copied into the ECRF. The Loney Repository at USC is developing a process for de-identification of the clinical scans. In the interim, coordinators need to obtain an e-copy in a timely manner from the PACS according to the storage and retrieval windows set at your site. The study coordinator's responsibilities are to work with the site team, again, to schedule this 3T MRI within 14 plus or minus 4 days from the time of injury. This will assure that we have effective patient communications, and pre-arrival planning for transport logistics to assure appointments are kept. Our experience from the TRACK-TBI pilot is that this is one of the most difficult things. First, getting the time slots scheduled for the MRI and helping to facilitate getting the patient there, and then also doing the follow-up outcome assessment if this is also being done at the same time. The study coordinator assistant's responsibilities are to complete the MRI scan information log, which is located in the appendix of the SOP, to document any technical difficulties and enter this into the data form in the ECRF. We want to understand where problems are occurring so that we can solve them. If the subject elects to discontinue the MRI because of discomfort, please enter comments explaining the reason for aborting the MRI scan. For the outcomes core, the study coordinator, the assistant's responsibilities are to coordinate and schedule the outcome visits relative to the MRI. As stated earlier, plus or minus 3 days for a 2-week MRI, plus or minus 14 days for a 6-month MRI. Roles in the outcome assessment administration may vary from site to site, and separate trainings have been conducted on those SOPs for the outcome assessment. I want to thank everyone for your hard work for our team. If you have any questions, please do not hesitate to reach out to us. This is a generational study, which many of us believe we will never have an opportunity to study this many patients again. We need to identify the patients that are most motivated, and everyone has to work as hard as they possibly can to ensure retention and follow-up of these patients. Again, thanks for your participation, and we are here to help with any questions that you have.